Morning, everyone. Welcome to Cardiac Sciences Grand Rounds at the end of February on this lovely spring morning. This morning, we have one of our own speaking, Dr. Liane Arcinas, who is a electrophysiology fellow now, is the chief fellow in electrophysiology. She has been in Calgary at the fellowship program coming on 2 years now. Prior to that, she's a native Manitoban, having gone to the University of Manitoba for both her internal medicine and core cardiology training. Liane is interested in staying in Calgary. We're hoping to kind of set things up if we can. And as part of that process, we're having her give her the grand rounds today, and she has chosen to talk about implantable electronic devices. So Liane, we look forward to your talk. Thanks.
Thanks, Dr. Howard, for the introduction, and thank you everyone for being here in person and by Zoom. So as we all know, electrophysiology is an evolving field, and there's been lots of shifts in cardiac device therapy. So I thought today would be a good idea to review them, just so everyone's updated in terms of the updates in cardiac implantable electronic devices. So in terms of what I'll do for my outline today, so I'll be quickly talking about history of cardiac implantable electronic devices, and then focus my talk on advances in cardiac pacing, particularly with conduction system pacing and leadless pacemakers. Then towards the end, I'll briefly touch on advances in defibrillators. So it's very fascinating to know that back in our, grandparents' time or in our great-grandparents' time, pacemakers weren't really around. And patients who have chronic high-grade AV block and complete heart block have dismal prognosis and very poor quality of life. It's expected that for patients who have chronic Mobitz 2 AV block and complete heart block, about 50% of them are dead in a year, and about 90% of them are dead in 5 years if they didn't get any pacemakers. And we see this all the time with our patients who come in and emerge with heart block. They come in with frequent episodes of syncope, pre-syncope, and sometimes even low cardiac output states secondary from their bradyarrhythmias. And so we're very lucky that in the 1950s, we started seeing pacemakers being introduced. And this is the first prototype that was created by Dr. Zoll, which I hope you are all familiar with. He's the father of modern cardiac therapy. And our cold blue crash cards have the Zoll defibrillator. And what he did is basically the first version of a transcutaneous pacemaker and also a defibrillator. And what you see here are surface electrodes that are put on the chest. And through this, Dr. Zoll was able to give about 200 volts of alternating current to pace someone at 2 milliseconds of pulse width. So you can just imagine how painful that is. Patients would have to be sedated and basically plugged into this big machine and can't really go anywhere. So it's not really a long-term solution for permanent pacing. Luckily, over that decade, we've had a few more advances in pacemakers, and by the end of 1950s, we saw our first fully implantable transvenous pacemaker by Dr. Almqvist, and it's molded after the kiwi shoe polish. That's why the shape is like this. It's made of acrylic, but the parts are essentially the same as the parts of our modern pacemakers. So you see here your generator, which has your battery and also the circuitry. And then this is plugged into transvenous leads that are put in the heart. And then it's fully implantable, so nothing's sticking out of the patient. And basically this prototype of leads plus generator has been the basic system of our devices. So they have changed in the look, but basically the components are the same. But in the last decade or so, we've had changes in terms of the way we implant pacemakers, where we specifically implant them and the specific looks of pacemakers, which I'll review shortly. So let's talk about advances in cardiac pacing. So I'll start with conduction system pacing, which is composed of His bundle pacing and left bundle branch area pacing. So these are the abbreviations, just in case you see this is what it means. So before I talk about them, I want to review RV apical pacing first. So the RV apex has been the standard pacemaker site ever since transvenous pacemakers were developed. And so for our learners who might be watching right now, just so you know that someone is being RV apically paced, you could see it by X-ray, and you could also look at it in the EKG. But your clues that there's an RV apical pacemaker is that you look at your AP view. Just remember your right heart border is composed by the RA mostly. The inferior heart border is by the RV, and then the left heart border by the LV. And so when you look at an AP X-ray, you'd expect an RV apical pacemaker lead to be going past the inferior border of the heart and crossing the spine and going towards the left, but not fully at the left because that would be the LV. And so this is someone who has an RV apical pacemaker. If you review someone who's RV apically paced on EKG, then you would expect that they would have a left bundle branch block because basically the electric wave front goes from the right to the left, and there's a delay going from the right to the left. And as you can imagine, that's really a non-physiologic way of activating the heart. Because normally when we activate the heart, it goes through your conduction system. So it goes from your SA node, AV node, his Purkinje system. So very fast activation, then to your myocardium. The way it works with RV apical pacing is you activate the myocardium first. And so you get myocardium to myocardium transmission. And so you basically get abnormal electrical and mechanical activation of the heart. And this, we know, if it's very frequently happening, can have deleterious effects to the heart. And so we know from previous studies that looked at patients who had devices that the higher the rate of their RV apical pacing, you have a higher rate of or risk of having atrial fibrillation, heart failure, and even increased mortality. Just to give you an example, this is an analysis of patients in the MADIT-2 trial. The MADIT-2 trial, as a reminder for everyone, is the trial that looked at primary prevention ICD in our patients with ischemic cardiomyopathy. And what they did is they looked at patients who were paced over 50% of the time versus those who were paced less than 50% of the time. And as you can see here, over follow-up, you see that those that were paced frequently, over 50%, almost have the same cumulative probability of mortality as their non-ICD counterparts. So with this, as well as the previous studies looking at high burden of RV pacing, we're really shifted towards minimizing RV apical pacing if we can, either through device algorithms or by something called cardiac resynchronization therapy via biventricular pacing. So in this, just a reminder for those who are not familiar, is wherein we put a coronary sinus lead in order for us to pace the LV, as you can see here. So what we do by putting a coronary sinus lead, we're able to pace the left side of the heart, and then we can coordinate that with the RV lead to be able to synchronize the activation of the heart where the left and the right are almost beating at the same time. So just to give you an example of how we do that in the device lab, this is a recent patient that we did last month who had a primary prevention CRTD device. And so this is your RV ICD lead in the RV, and we access the coronary sinus by putting a sheath basically in the coronary sinus. Let's see if it displays. It's not playing as much. And then we do a venogram or a balloon wherein we shoot a dye and figure out the tributaries of the coronary sinus. We aim for the lateral or the posterior lateral tributary of the CS. And from there, we put in a coronary sinus lead. We want it to be as leftward as possible in the heart so that you could pace the leftmost side and also the RV side of the heart. And normally what you would expect if someone gets a CRT is that usually we give it for patients with left bundle. So it would change the left bundle to a right bundle branch block. The QRS would still be wide, but this is the usual CRT findings ECG findings on someone who has a CRT. And I've mentioned lots of landmark clinical trials already have been looked at for CRT or biventricular pacing for heart failure patients. But at the same time, it's been looked at on patients who have an indication for pacing and systolic dysfunction. And I'm just going to highlight one of the biggest studies on this that was published in NEJM in 2013, which is the Block HF. So the Block HF compared biventricular pacing versus standard RV pacing in patients with an indication for pacing and an EF of less than 50%. And so they looked at the primary outcomes of time to death from any cause, heart failure, or increase in their left ventricular end systolic volume. And as you can see there, for those who were biventricular pace, the percentage of events were less compared to those who were RV apical paced, with a 10% absolute reduction in primary outcome. So with these results and what we know in terms of the effects of biventricular pacing and advantages of it compared to RV pacing, we are all familiar with this. I'm just going to review the guidelines. But if you have someone who has an EF of less than 50%, what we normally do is, check the indication if they have an indication for pacing, if it's an indication for high degree AV block or complete heart block, and we expect that they're going to be paced very frequently. What we usually recommend is obviously start them on medications for HFmef and also to proceed with a CRT instead of standard RV apical pacing. However, as you could imagine, biv pacing is still not physiologic. That's still not how you activate the heart. You still go from myocardium to myocardium instead of going through your own conduction system. And unfortunately, up to 30% of patients are non-responders. So when you follow them up, their heart failure doesn't get any better, their EF doesn't improve, their LV is still big, they still have symptoms. And another thing is technically up to 3 to 10% of patients, depending on which center you are, there could be a failure to cannulate the coronary sinus. So it could be very hard to put a CS lead. I'll just give you an example. Another patient that we did last month who also had was supposed to have a CRT, but as you can see here, he had a very large Buson's valve that was obstructing access to the lateral tributaries of the CS. And this is just a diagram just to make you appreciate where the Buson's valve is. And so normally we aim for lateral and posterolateral CS, but we weren't able to do that because this person has a very non-pliable big Buson's valve. So back then we would have been, okay, I guess we'll give up. There's not much that we can do. But luckily now we do have the option of putting a conduction system pacemaker. And that's what I want to review now on what conduction system pacing is. And so essentially it's what the name says. It's the implantation of a permanent pacemaker lead along different sites of the cardiac conduction system. And there's two modes of delivery. It's either through the His bundle or the left bundle branch area, which we call left bundle branch area pacing. And this is just a diagram to show you how it looks like. His bundle pacing has actually been around for quite some time, almost 20 years now. And it's a fixation of an active lead in the His bundle. And so just to compare what it looks like on X-ray, when we reviewed RV apical pacing, it's quite here, it's close to the diaphragm. Here, your His bundle is at the base of your heart, just below your LVOT. So when you look at the X-ray, it almost looks like an RA lead, but this is actually a His bundle lead. And it's described, as I mentioned, as early as 2006. Theoretically, it's the most ideal site to pace because you're essentially just activating your own conduction system. Your EKG would look exactly as how it would be like if you were just going through your own conduction system. So just to give you an example, this is a patient who had intermittent complete heart block. This is what their EKG looks like at baseline. They had a selective His bundle. And if you didn't see the pacing spikes here, you wouldn't even realize that this person is paced because the heart is activated exactly how it would be activated via conduction system. However, many of you might be wondering, why don't we see so many people walking around with His bundle pacing? This has been around for so long. But His bundle pacing, unfortunately, has lots of limitations. It's very technically challenging. And just to give you an idea, this is just a gross anatomy of the heart. So your His bundle is located in the membranous septum, and it's very short. It's like 20 by 4 millimeters. So you really have to be able to target that area to be able to get to the His bundle. And people who are in the EP lab know this. Sometimes it's really even hard to get a His signal in your His catheter. So imagine just like trying to, pace the His bundle. And as you can see there, because it's so small, the area, it's a very long learning curve if you want to learn about it. Just to give you a comparison, this is how big the left bundle branch is and the right bundle branch is versus the His bundle, so tiny area. The other limitation is the His bundle is usually surrounded by inert tissue. So fibrous tissue doesn't really conduct electricity. So in order to be able to pace the His bundle, you actually have to be very close or at the His, because if you're just pacing the inert fibrous tissue, then you might not capture the His. Or you might need very high thresholds or outputs to be able to capture the His. So because of that, you have your limitations number 2 and 3, where you have threshold challenges. You might need high pacing thresholds. You might have threshold increases over time, and you might need to revise the lead over time. And this is particularly scary for patients who are pacemaker dependent, because you don't want their his bundle lead to just not work, because then that would be a lawsuit. Then also in terms of the R waves that you see, they usually are small, and you might have atrial oversensing because you're close to the atria, and ventricular undersensing. Luckily though, by 2017, we have another option for conduction system pacing, and that is what we're doing right now, mostly in Calgary, which is the left bundle branch area pacing. And this is exactly what the name suggests. Instead of putting a pacemaker lead in your his bundle, you can put a lead along your left bundle branch, and there's many options. You can do left anterior fascicle, left posterior fascicle, more proximal left bundle, so you have lots of leeway. The interesting thing is it was actually first described in a Canadian journal. So it was published in the CJC in 2017, although Dr. Wang performed it in China. But it's just a nice local national flair. And for more local flair, if you didn't know, Dr. Rascala was actually the first ever Canadian electrophysiologist to do left bundle branch area pacing in Canada. So he actually brought it in from Boston. And when he came here in 2019, he did both his bundle and left bundle branch area pacing. So just to give you an idea on how we figure it out anatomically, if we're by the his bundle or the left bundle branch, remember that your his bundle is actually just below your aortic cusp. So you could imagine when we have patients who have TAVIs or AVRs, how close it is to your conduction system. That's why you see heart blocks in some patients. But when we put the his bundle lead, we aim for this area. And the left bundle branch is just posterior and anterior to the his bundle, about 15 to 20 millimeters, they say. And that's what you aim for when you look at it by fluoroscopy. And then there's just a good image of someone with a TAVI, so you could compare how his bundle versus left bundle looks like. And when you look at CT scan, sometimes it could be scary because your left bundle is quite buried into interventricular septum, but that's what we want because we want to reach the left bundle. So just to review the benefits of left bundle and advantages over his bundle pacing. With left bundle branch area pacing, lots of leeway, you have a wider target zone. And the other thing is with the left bundle, it's surrounded by muscular tissue. So muscle can conduct electricity. So even if you're not exactly at the left bundle branch, you can capture the left bundle. With that, you have lower thresholds. It tends to be more stable. And because of that, you have longer battery longevity. So just an FYI for us, because we all read EKGs, and just so you're familiar with what the EKG would look like for someone who's left bundle branch area pace. And this is what we look at in the OR and also basically in the EP lab if we're doing it in the EP lab. But what we do in order for us to know that we're in the left bundle branch and pacing from there is we start pace mapping first. So initially, obviously, you start on the rightmost side of the interventricular septum, and from there, you're gonna hit the right bundle. And initially, what you'll see is what you would expect with someone who's RV pace. You'll see a left bundle branch like morphology. But as you bury through the interventricular septum, you see a W pattern or an RSR prime pattern. And as you go deeper and deeper and at the left bundle, that R prime moves on to form a RSR prime pattern. Basically, we call it a right bundle branch conduction delay pattern. The interesting thing with this one is if you're successful with the left bundle branch air pacing and the patient doesn't really have significant distal block to it, is that your right bundle branch conduction delay pattern is actually narrower than a right bundle branch. Because if you imagine, you're still pacing the conduction system, you're not pacing the myocardium. So your activation of in your interventricular septum is still very fast because you're pacing the conduction system. So usually when you measure your QRS, even though it's RSR prime, your QRS should be less than 120. The other thing that we look at is what we call LVAT, or the left ventricular activation time. So if you think about it, if you're pacing your left bundle, your left ventricle should be activated very quickly because you're going through the left bundle. So what we do is we measure the activation. So basically stim from VS, so from V6 up to the peak of the R. Usually we aim for less than 90 milliseconds. So if you see those and other criteria, we know that we're successfully pacing the left bundle branch area. So just as a recap, what we look for, and you might see this when you're reading EKGs of patients who have a left bundle branch area pacer, is you'll see a right bundle branch conduction delay pattern. And if you measure the LVAT, it's usually less than 90 milliseconds. The first part is you can only see if you have an EP recording system, is sometimes you might see a left bundle branch potential when you're pacing. And then there's other criteria that you could look at to know if you're selectively versus non-selectively capturing the left bundle. So just to give you examples of cases that we've done and what their EKGs look like. So this is a patient of Dr. Ilhans, who came in with syncope with baseline bifascicular block and 2-to-1 AV block. So his EF is 55 to 60%. And as you can see here, I'll just review. So this patient has a baseline right bundle branch block. QRS is actually wide at 142. And he also has left anterior fascicular block. He ended up having a left bundle branch area pacing lead. And as you can see here, the paced QRS is even narrower than your baseline right bundle. You see the QRS is now shortened to 98 milliseconds, so it's not even a right bundle branch block. It's narrow. And then if you measure the LVAT was 66 milliseconds. You have really good threshold and good R waves. And in terms of skin-to-skin time, it's pretty good. Dr. Ilhan did it within 1 hour and 19 minutes with less than 5 minutes of fluoro time. Another example is by Dr. Furlanis from Red Deer. So this is someone who has a dual chamber pacemaker that was put in 2011 for type 2 second degree AV block. He's paced almost all the time on device interrogation, and his EF dropped from 60 to 45 to 50. So the hypothesis is maybe this patient has RV pacing induced cardiomyopathy because they're paced all the time. So let's upgrade with the left bundle branch area pacing lead. So just to give you the baseline QRS, you see here that the patient has a wide left bundle because they're chronically paced. QRS is 182. And after the addition of a left bundle branch area pacing lead, you see this RSR prime pattern again on V1. Your QRS narrowed down to 103 with an LVAT of 77 and really good R waves. And with this one, Dr. Furlani also performed it in a short amount of time, 1 hour, 5 minutes with less than 3 minutes of fluoro time. Obviously, it's not always this easy. Sometimes putting a left bundle branch area pacing lead could take as long as putting a CRT, especially in patients with structural heart disease. But it can be done to be as short as someone who's just getting a regular RV apical pacemaker, like with this cases. So we're just not doing it to get good EKGs, obviously. What's the evidence? Why are we doing it? So luckily we have some evidence now. More will be coming on the way. So in terms of the evidence comparing left bundle branch area pacing versus RV apical pacing, we've had this one as one of the observational studies that was published in Heart Rhythm by Dr. Sharma, wherein they looked at patients who had an indication for pacing for bradycardia, and those who had left bundle branch area pacing versus RV pacing. And they looked at the outcomes of mortality, heart failure, or needing to upgrade to a biventricular device. And left bundle branch area pacing people are here in blue. And as you can see, the events happened less in your left bundle branch area pacing patients compared to those who got standard RV pacing. What's more interesting is when they even did a subgroup analysis and just looked at patients who were paced more than 20% of the time, the difference between groups have been even more marked. So you see a bigger benefit in those who had left bundle branch area pacing in terms of the primary outcome, mortality, and heart failure hospitalizations. So they concluded that left bundle branch area pacing is associated with improved outcomes, especially for those who need to be ventricular paced more than 20% of the time. How about for biventricular pacing? Do we have some evidence so far? So Dr. Vijayaraman is one of the he's spearheading the left bundle branch area pacing trials. And so this is one observational study that he did. This was a retrospective observational study that essentially looked at patients who had an indication for CRT and compared those who had a biventricular pacemaker or a left bundle branch area pacer. And they looked at time to death or heart failure hospitalization. Unfortunately, because this is an observational study, they didn't really randomize. So the operator could decide if they want to put a left bundle branch area first or a biventricular pacemaker. And I'll just show you the results. It's busy, but I'll highlight the important ones. But they looked at QRS duration with the left bundle here versus biventricular pacer here. You could see that compared to baseline, you've had a narrower QRS. And if you compare left bundle branch area pacing with biventricular pacing, you even have a much narrower QRS, which is kind of expected because you're activating the conduction system. Other thing with the NYHA class, they found a difference in baseline between both groups, but much more improvement in NYHA class in left bundle branch area pacing. And when you looked at ejection fraction, you had a difference in or improvement in your ejection fraction, and even more marked improvement in the patients who had a left bundle branch area pacer. When they looked at clinical outcomes, which is death or heart failure hospitalization, left bundle branch area pacing is in green versus biv pacing. They even they showed a much more marked difference in terms of outcomes in those who had left bundle branch area pacing. So less of the events occurring in them. And then when they did a subgroup analysis where they just focused on patients who had left bundle branch block only, you see the difference between the group was even more prominent. So they concluded that left bundle branch area pacing improved clinical outcomes compared to biventricular pacing and could be considered as an alternative to biventricular pacing for patients who have CRT indications. So with this data, there has been updates in the HRS guidelines, and I just want to review them for everyone. This was just published in September. So they published guidelines in terms of conduction system pacing in lieu of RV apical pacing, and especially for the ones who are expected to be substantially RV paced. So if you have someone who has an indication for pacemaker therapy, and you expect that they will be paced more than 20% of the time, that was their definition of substantial ventricular pacing, then you have the option. Well, obviously look at their EF first, see if their EF is decreased. And if it is less than 50, they recommend either as conduction system pacing or CRT with biv pacing instead of just having a regular RV pacemaker. How about in patients with heart failure? In terms of the guidelines, class 1 indications still don't change because the data that we have for biventricular pacing is so strong. So if you have someone who has a class 1 indication for CRT, so EF less than 35, left bundle branch block, wide QRS, symptomatic heart failure, you should aim for biv pacing because that's where our data is right now in terms of RCTs. But the good thing now is if you can't put a coronary sinus lead for some reason, then you should aim for a left bundle branch area pacing lead or his bundle pacing lead, but we don't do that much here. So at least you now have that option with a class 2A indication. For those who have an EF that's kind of borderline, and if you really have to put a pacemaker for them for some reason, the data for biventricular pacing is really not as strong. So they put conduction system pacing and biv pacing in the same level of recommendation if you have to give them a resynchronization device. And then this is for non-left bundle, which we rarely do anyway. And this is another thing. So if you have someone who has pacemaker-induced cardiomyopathy, the data that we have so far with block HF class 1 is still trying for biventricular pacing. But if you're unable to do it, or if the biventricular pacer is not working, then you can revise and give a CSP. So just as a recap, as I mentioned, for biventricular pacing, there's been so many studies with thousands of patients, proven data. Unfortunately, for conduction system pacing, these are the only RCTs that we have so far. So the patients are still less than 200. So we need more RCTs to be able to get to class 1 recommendations. And so that is why I want to highlight some of the studies that were involved here in Calgary. So the one that we're most excited about and that we're currently enrolling in Calgary is the left versus left trial. And this is an RCT comparing left bundle branch area pacing versus biventricular pacing in patients who have an indication for CRT. And we're enrolling, as I mentioned, with our site PI being Dr. Exner. We have other things that are coming along the way as well with left HF, wherein you compared left bundle branch area pacing versus RV pacing in patients with EF less than 50% and higher RV pacing burden. That will be spearheaded by Dr. Chu here in Calgary. And then we have a few more, another one coming up, which is the RAF PNA, wherein you compare left bundle branch area pacing versus biventricular pacing in patients undergoing total AV node ablation. If you do a pacing ablate strategy, which one is better? Do you do left bundle? You do biventricular pacing. So those are the upcoming clinical trials along the horizon. And then lastly, I just want to end with complications and limitations of left bundle branch area pacing. Because it's a relatively new technology, we don't know what the extraction data is so far for left bundle, because we really haven't extracted as much patients. And of course, we worry about, would we cause a big VSD if we extract the left bundle branch area pacer because it's quite deep in the interventricular septum? We don't know. Um, Other thing too is you need an EP recording system or a 12-lead EKG beside you when you're doing it, because you always have to check the EKG if you're screwing it in the right area. So you can't just do it blind. So it requires a bit more in terms of the technologies in the OR when you're doing it. And the other thing that's a bit more unique with left bundle branch area pacing is you could have, as I mentioned, VSD or acute and delayed septal perforation. So when we do left bundle branch area pacing, it's not uncommon to be able to have a septal perforation or a VSD. And we don't really worry much about it because the hole is very tiny and it's in the muscular interventricular septum. It's not really hemodynamically significant. And what happens is the impedance on your lead just drops. You're contacting blood. And what you do is you just pull it out, you just implant in a different area. So we don't worry much about that because we recognize acute septal perforations in the OR. The thing that we worry most about is obviously delayed septal perforation, because for that, you don't recognize it in the OR and the patient might present with a stroke because they have a lead in their LV. So that's just one thing to think about. That could happen with RV apical pacing too, but with left bundle branch area pacing, because you're screwing it in the septum, then you go straight to the left if you go perforate. So those are the limitations and complications for left bundle. Now I want to move on to leadless pacemakers. Completely different. And so with that, I just want to review the complications associated with transvenous pacemakers. So these are the things that we usually quote our patients when we consent them for a pacemaker. So one thing that we kind of see in patients with a transvenous pacemaker is they could develop a pneumothorax, because in order for us to access their vein, we use needles to get to the axillary vein or the subclavian vein, and you might accidentally poke the lung. Other things that are seen in transvenous pacemakers is pocket-related complications. So someone might bleed in their pocket, and that pocket might get infected, and obviously lead dislodgement as well. These are just a few examples of some cases that we had who had complications post their device. So A and B is someone who had a large pneumothorax. In this case, they had a really difficult time getting access on the left. So that's why they switched on the right and was able to eventually get access to the right. But post-op, you see here a ginormous pneumothorax. So this person needed to stay in hospital, needed to have a chest tube. Another one is this, which you don't want to see, but the patient presented with diaphragmatic stimulation. And that's because you're pacing the diaphragm, because you're out of the RV. Other one here is someone who has a device erosion. So you see here the generator sticking out. So that's a device infection until proven otherwise. So you'll have to extract the whole thing. And then here in F is someone with Twiddler syndrome, who basically played with their pocket and twisted their leads. And you see here the right atrial lead is by the generator, and their ICD lead is in the SVC. So those are a few complications that you could get with transvenous pacemakers. So in terms of leadless pacemakers, we have two options here in Calgary. We have the Micra from Medtronic, and we also have Avir from Abbott. And just to give you an idea on how tiny and cute these devices are, the Avir pacemaker is smaller than a AAA battery, so tiny. And the Micra is the smallest adult pacemaker that we could give to adults, and it's the size of an almond. So very tiny pacemakers. And we're very lucky here in Calgary because we have, pioneers who lead leadless pacemaker technology and also train trainees across Canada in terms of putting leadless pacemakers. So we have Dr. Exner, who has been involved in the RCTs with Avir and has been putting Avirs in training electrophysiologists across Canada with the Avir insertion. We also have Dr. Kuriachin here who's doing Micra as well. So luckily we have a lot of electrophysiologists who could implant this here in Calgary, which is nice. And this is just the simulation that Dr. Exner did with us in terms of how to put an Avir. And I just show a picture here just to give you guys an idea on how big the sheaths are and how long the sheaths are. The sheaths are taller than me. I'm only 4'11", but they're very long. And they're in 27 French sheaths. So something to keep in mind if you have a very tiny person who might have a tortuous vein, you have to put a really big catheter in their femoral vein. So just a comparison between the two leadless devices. The Micra, as I said, is smaller. They're both made of titanium, and they use lithium for their battery. And they have really good batteries now. So the Avir has expected battery life of about 10 years versus the Micra, which is even longer at 17 years. The big difference between these two groups is that the Micra uses passive fixation versus Avir uses active fixation. So in order for the Avir to be implanted in the heart, you actually screw it in the interventricular septum, versus with Micra, you don't screw it anywhere. You just have the tines grasp on the RV trabeculation and stay and hope that it stays there. But it usually stays there. We check to make sure that it stays. So that's the difference between the two. The other big difference between the two leadless is the Avir has its own retrieval system. So if for some reason you want to take it out and reposition it, it just comes with a kit where you could retrieve it. With Micra, it doesn't have a retrieval system, but you can still remove it, but you'll have to use the Avir retrieval system to be able to get it. And I'll show you later a video of how we do it. And the other difference is with Avir, you can start mapping even before you implant. So you can check if you have good thresholds, or if you're in good area before you screw in the heart. Versus with Micra, you have to deploy it first before you know if you're in a good area. So those are the difference between the two groups. The two pacemakers. So just perioperative considerations for these two. So as I mentioned, it's a big sheath. You need 27 French access site in the femoral vein. And if you have someone who has a left bundle, we usually put a temporary pacemaker, because if you bump the interventricular septum, you might go asystole, and you don't really want that during the procedure. You don't really need to be in GA. The patient just has to be deeply sedated, because you don't want them moving their leg as you're putting it. And consequently, also, you want to make sure that they are able to do bed rest at least 3 to 4 hours so that the groin would heal. We usually put 2 perclos plus or minus a Z suture for the groin. And you also check it on X-ray. So what do we have in terms of our data? Unfortunately, the data that we have is on nanostim, which is the precursor to Avir. We don't do nanostim anymore, but I think the comparisons are still very helpful. So this is just a comparison in terms of short-term and long-term complications for leadless pacemakers. So these are the short-term complications with leadless. And as you can see here, transvenous is red, and you essentially see no complications with the leadless whenever it comes with the chest and the pocket. So thoracic trauma, you don't really get pneumo because you don't access the axillary veins, and you don't get an infection because you don't have a pocket, and you don't get a hematoma because, again, you don't have a pocket. You might get a hematoma vascularly in the femoral area, but not on the pocket. The biggest issue in terms of the leadless is the immediate short-term complications. So particularly with the Avir, because you actively screw it in, you come with the risk of cardiac perforation. And the perforation that you see with the Avir pacemaker is catastrophic. It's like you puncture through the heart, need cardiac surgery right away. It's not like the perforation that you get with a small RV lead. So just something to keep in mind. And then in terms of midterm and long-term complications, you really avoid that with a leadless pacemaker. No risk really of infection or pocket related complication. So when do we start thinking about referring someone for a leadless pacemaker instead of a traditional transvenous pacemaker? So really, if you have someone, let's say an end-stage renal disease patient, no access, bilateral mastectomies, think about a leadless pacemaker. Especially also if you have someone who already had a previous device infection, ideally you would not want to put another transvenous device because they already showed to you that they could be infected with their transvenous pacemaker. So these are the people that you should start thinking about referring them for a leadless device instead of a transvenous device. Just some absolute contraindications. That includes a mechanical tricuspid valve, IVC filter, because we go through the IVC to put it. And then we can't really implant it with a transvenous ICD because if you shock, you might actually affect your leadless pacer. These are just the factors that really help the leadless pacemaker to not be prone to infection. And the biggest really is you don't have any pockets or leads, because that's really the source of your infection. If you have access to the skin infection could go in and infect your device. The other thing too is your leadless pacemaker has a very small surface area. It gets encapsulated right away. It's coated by parylene, which is very protective against infection, versus transvenous leads. They're usually with polyurethane. And lastly, the RV apex and the interventricular septum is a turbulent environment, so it's less likely for biofilm to form there because the flow there is very fast. Again, as I've mentioned, for leadless pacemakers, it's almost a case report if you have a leadless pacemaker that's that's infected. We rarely see it. And with that, there has been studies that looked at the possibility of extracting transvenous pacemakers and putting a leadless pacemaker at the same time. And we actually are doing that here in Calgary now with the approval of ID, if ID is okay with it. If we have patients who have, let's say, a device erosion with no bacteremia, and if ID is okay, we remove their transvenous at the same time, put a leadless pacemaker, and that helps save the patients, a prolonged admission in hospital. Just to give you an example of what we did, this was also last month. We had a patient who had a dual chamber pacemaker in 2012, but he became, very cachectic, lost a lot of weight, started having device erosion, and then boop, suddenly their device popped out. So this is infected. Luckily, his blood cultures were not positive, and we admitted him. And based on what I told you, in terms of what would you do, you wouldn't just leave chronic antibiotics, and this person would be a high risk of infection if you implant another device on the right side. So what we decided to do is to extract it and implant a leadless pacemaker at the same time. So I'll just show you how it looks like and what extraction looks like. So we use laser sheets or mechanical sheets to remove leads. So this is just us removing the ventricular lead. This is us removing the atrial lead. So lots of tugging and pushing. And then when we were able to remove the lead, we then switched to putting the the leadless pacemaker. You see here a transvenous temporary pacemaker because this person was pacemaker dependent. And then this is just a RV gram to see what the RV looks like so we could help with their positioning. And this is the AVIR when we place it in the heart. So it comes from the IVC. You put it through the interventricular septum. You try to find a good area by the RV apex. And then you shoot some venogram again. And then once you're happy with your position, you then move on to removing that protective sheath across the AVIR, and then that makes you expose the helix. And then the helix you screw in the interventricular septum, and you screw it one and a half turns. And then when you're happy, what you do is you put the device in tether mode. You don't let go right away, but there's a tether at the end of the delivery sheath and the AVIR. And what you do is you check with flexion and deflection, make sure that the device is stuck there and not moving anywhere. And when you're happy, you cut the tethers and you have a leadless pacemaker. It looks big here because it's in Zoom. But if you actually look at the X-ray, it's so tiny. It's like just having a USB across your chest, which is nice. And this is just a video of a leadless extraction and how we do it. So this is someone who came in with, as you can see here, the leadless is not really in a good position. It's pointing up towards the RVOT. It should be pointing more towards the interventricular septum. So if you want to extract it, what you do is you get this extraction tool or kit from AVIR. There's this knob at the end of the device, and you basically ensnare it. And then you get it, you dock it back in your AVIR. You put a protective sheet. And then what you see is you basically unscrew it and then you pull it out. And that's how you extract a leadless. So lastly, I want to end with upcoming technology, particularly with defibrillators. So we have future directions now in terms of subcutaneous ICD. So as you know, for subcutaneous ICD, they can't really pace, unfortunately, but now we have the Empower leadless pacemaker that you could actually put in the RV. And the way that you could do it is that if someone is in ventricular arrhythmia, it could coordinate with your subcutaneous ICD, and the leadless pacer could provide ATP. And if the ATP doesn't work, then the subcutaneous ICD would then shock the heart. The other thing that I think we're also involved in terms of the study. I think Dr. Kuryachin performed this already as well, is the EV-ICD or the extravascular ICD. So this, again, there's no transvenous access, everything's subcutaneous, but the lead you actually put behind the sternum. So you need cardiac surgery with this, but the lead could pace, and then the subcutaneous ICD could shock. And then lastly, we have the leadless CRT or the YCRT. And this involves putting a receiver electrode in the endocardium of the LV. Sometimes you could actually, there's a case report already where they implanted it in the left bundle branch area. And you could pace with a transmitter, which then would coordinate with your co-implant. But this one is not fully leadless. You still need a transvenous device to coordinate. And this is another option for patients who can't have a coronary sinus lead for some reason. So this is just a good summary. Feel free to refer to this in terms of the resources for our pacing options now for our patients. And then for take-home points, I just want to summarize. Conduction system pacing should be considered in all patients who are requiring significant RV pacing. And CSP can be used as an alternative to the IV pacing now. And consider leadless pacing in patients who have a risk of high infection or limited venous access. And with that, I want to end with thank you to all these physicians who helped me with my slides and also a picture of my dog. Thank you.
So we'll open up to questions, both in people either want to put questions in the chat online. I'll open up.
It's Kristen Lyons. If I could ask a question remotely, that was a wonderful talk. Thank you so much. I'm just wondering now in Calgary, I've seen some patients receiving, obviously, the conduction system pacing. Outside of a clinical trial or say someone who's failed CRT, are you guys in the heart failure patients with LVEF less than 35% doing that in really anyone? Or are you sticking with the IV pacing outside of those two unique situations?
Sure. We've actually had cases wherein we upgrade patients to left bundle branch area pacing if their coronary sinus lead is not promoting biventricular pacing. And it's also operator dependent. Sometimes some operators actually decide to put a left bundle branch area pacing first instead of coronary sinus lead if they expect that the anatomy would be very difficult and it'll be difficult to put a coronary sinus lead. But thank you for the question, Dr. Lyons.
Thanks. Great talk again.
Thank you.
So I have a question for you. I understand that when we compare physiologic pacing off the bundle versus RV pacing or not, have worse outcomes. More heart failure. But do we understand the pathology of what? Not like we've been putting pacemakers. What do you think's happened?
I think there's a few things. There's probably patient-related factors as well. We know that for RV pacing-induced cardiomyopathy, not everyone gets it, even though many people get an RV apical pacemaker. Only about 15% of patients get RV apical pacing. So I think it's a mixture of the burden that they're getting RV paced, and it might be that the patient itself, in terms of their myocardium or their genetics or something that makes them prone to developing cardiomyopathy from RV apical pacing. But the unfortunate thing is we can't really predict who will have RV apical pacing. So if we could, try to avoid RV apical pacing altogether, then we might minimize the risk for those 15% of patients. But yeah, I get what you mean too. Sometimes we don't know, and sometimes it's so hard to put a left bundle branch area pacer that maybe if someone gets an RV apical pacemaker, it should be okay, and they might not get any RV pacing induced cardiomyopathy.
Again, you didn't talk about how much the difference in costs would be between standard RV pacing and PEN conduction system pacing.
Oh,
Comment on that?
so Dr. Kavanaugh was just asking the difference in costs for left bundle branch area pacing versus RV apical pacing. I actually don't have that on the top of my head, but I would assume it's more expensive currently to put a left bundle branch area pacer because as I said, you even need like an EP system to be able to do it, or like a continuous EKG. So that itself requires more in terms of the requirements from your OR or from your EP lab. And in terms of the lead itself, I'm not too sure if the 3830 is more expensive than the regular pacemaker leads. Do you guys know? Do you know, Jeff, Vinny? Similar price?
It's the sheets.
Oh, it's the sheaths. That's right. So yeah, we use sheaths to put in the left bundle branch area pacer versus for, standard RV lead, we just use a regular safe sheath, which would be much cheaper. But the special sheaths that allow us to direct to the left bundle would be more expensive. Thanks. That's a good point.
And can we do it in all of the rooms that we presently get put in to do pacing?
No, yeah, that's the other thing in terms of our room requirements, because we need the EP recording system. Usually we recommend that it's be done in OR 35, which is in McCaig, or in the EP lab. But Dr. Ilhan has actually been doing it in the OR 1, the main OR, without the EP BARD system. So the way he does it is he just sets up the EKG machine of the anesthesiologist, and he essentially just needs V1 and your 2, 3, and AVL, and he could figure out from there if you're by the left bundle branch. So there's ways. And in Red Deer, because they don't have BARD, what they do is they just have a continuous EKG. And so as Dr. Furlani screws in the lead, he just looks at the EKG. So that's also doable.
And to go back to Dr. Howard's question, okay? A lot of the patients that we put pacemakers in are older patients. And they may not be paced as much. And I don't know if any of your studies have looked at the patients that get the age of the patients, okay? A lot of our patients are older, may not be paced for quite as long. And should we be doing a induction system in those patients versus younger patients is another way of looking at who gets cardiomyopathy, who don't get cardiomyopathy.
Yeah, thank you for the point, Dr. Cavanaugh. Dr. Cavanaugh was just mentioning that it might be different in terms of the effects in patients who are a bit older versus younger. Would the older patients still benefit from left bundle branch area pacing, especially if not paced all the time?
Any other questions online? You can just speak up. I'll ask the room again. I guess you're off the hook, yeah. Thank you very much.